The following video demonstrates a safe and effective method to enter into the uterine cavity using hydrodilation without the need for mechanical dilation of the cervix. A technique to overcome cervical stenosis and false passages will also be demonstrated using hydrodilation and a hydrophilic guide wire. Stenosis of the endocervical canal is a difficult challenge to overcome when encountered at the time of hysteroscopy. Mechanical dilation of a stenotic cervix can potentially lead to damage to the wall of the endocervix and creation of a passage within the cervical stroma. Creation of a false passage subsequently leads to obliteration of the endocervical canal and often requires the surgeon to discontinue the procedure or risk perforating the uterus in an area prone to bowel, bladder, ureteral, and vascular injury. Hydrodilation is a method that utilizes hydrostatic pressure from the hysteroscope to dilate the endocervical canal, allowing the surgeon to direct the hysteroscope into the uterine cavity under direct visualization. Prior to performing hydrodilation, it is important to first focus the hysteroscope on an object several millimeters from the lens. The hysteroscope is then placed at the opening of the external os of the cervix. The hysteroscope is then directed into the uterine cavity, driving through the endocervical canal under direct visualization. Although hydrodilation is an effective entry method in most instances, cervical stenosis still poses a problem. The hydrostatic pressure is unable to adequately dilate the cervix enough to accommodate the diameter of the hysteroscope. Lysis of endocervical adhesions using sharp dissection is one option that has been employed to resolve the issue. But not knowing the direction of the endocervical canal behind the area of stenosis can be misleading and places the patient at risk for perforation at the level of the cervix. A safe and effective method to overcome cervical stenosis employs the use of a straight-tipped hydrophilic guide wire, which is readily available in most operating rooms. The tip of the guide wire is flexible enough to prevent damage to the endocervical canal, but the rigidity and diameter of the guide wire allows easy passage through an area of stenosis. The guide wire is able to be passed through the operating channel of the hysteroscope with the help of the white plastic introducer. The guide wire is then advanced through the hysteroscope and directed through the area of stenosis. The guide wire is then held in place while the rest of the guide wire is pulled through the hysteroscope. The white plastic introducer is then passed over the wire, and the distal tip of the introducer is used to dilate the cervix as demonstrated here. Note that the use of the introducer piece in this manner is off-label. With the distal tip length of 2.5 centimeters and the outer diameter of 3 millimeters, the introducer piece is an ideal tool to dilate the cervix. With a total length of 5 centimeters and a maximum outer diameter of 5 millimeters, uterine perforation or overdilation of the cervix is unlikely. With the endocervix now dilated to 3 millimeters, the hysteroscope can now be passed through the previously stenotic endocervix using hydrodilation. Here, a second case of cervical stenosis is encountered. Hydrodilation was first attempted and abandoned due to damage of the endocervical walls. The issue was quickly resolved using a hydrophilic guide wire and the introducer. A false passage in the endocervix created by mechanical dilation can also be resolved using a guide wire and dilator. In this instance, a vessel dilator from a central line kit was used to dilate a stenotic cervix in the presence of a false passage. Stenosis of the endocervical canal is a difficult challenge to overcome when encountered at the time of hysteroscopy. Mechanical dilation of a stenotic cervix has the potential risk for perforation at the level of the cervix and injury to the bowel, bladder, ureteral, and vasculature. When cervical stenosis or creation of a false passage does occur, a technique demonstrated using hysteroscopic hydrodilation and hydrophilic guidewire is a safe and effective method to resolve these issues.